Yes.
Thank you guys for having us here to talk a bit about CBT, one of our favorite things. So we'll be talking about the benefits of CBT and how it ties into clinical skills. And I think most of you know Brian Krasan is now the CBT consultant trainer who will be mainly working with the first teams of being the kind of primary consultant there. So he and I worked on this together, and we thought it'd be kind of cool to kind of co-present this. So I'm going to start and then hand the baton off to Brian after I get going for a little bit. So what are we going to try to do today? We're going to cover just a little bit on the effectiveness of CBT from a research standpoint. And then we're going to try to drill down on some of the components of CBT that we think are helpful, and then try to use two kind of common areas to kind of highlight that, hallucinations and negative symptoms. And then we'll just do a little brief commentary, a little bit about ongoing consultation related to CBT stuff. So what is cognitive behavioral therapy for psychosis? It is an evidence-based therapy which aims to do two main things, and that is decrease distress and improve functioning. A lot of the early research was on seeing what impact it would have on symptoms, but our emphasis is really on lowering distress so that a person can do the things that are important and meaningful in their life. So there's a really strong emphasis on personal recovery goals, working in this particular therapeutic modality. Just a little bit about the benefits of CBT from a research standpoint. Um, Numerous meta-analyses and randomized control trials have been performed on CBTP. I've only listed a couple here. In particular, the Turner study kind of looked at the up to that point, all the meta-analyses that had been done, and they had concluded really that there has been enough randomized control trials to show that CBT is beneficial. We don't need to repeat all those studies. The outcomes pretty consistently when using a formulation-based CBT. CBT outcomes are better for hallucinations and delusions compared to treatment as usual, and significantly better compared to even active control. So if there's another treatment that's included or compared to, it does better there as well. Not as strongly with delusions, still better than treatment as usual, which is normally just medication. So anyway, we've got pretty good evidence that CBT is beneficial in many of the ways that we would like. We included one guideline here. There are several guidelines. This is the SAMHSA one. It's one of the more recent, 2021, really outlining some of the evidence and making the case for routine use of CBT when individuals experience psychosis, similar to what occurs in the UK and in Canada when an individual has a diagnosis in the schizophrenia spectrum. They're recommended to get and entitled to get so many sessions of CBT. So some things to look at along those lines. So we asked the question, what makes CBT beneficial? And when we kind of drill down, there's a couple of things we think are important. One, that it's grounded in a theory and a model that makes sense and that has been tested. Related to that, one of the tenets of CBT is it must be individualized. So we have a general model of how hallucinations work, negative symptoms, but for each individual, we must understand their life and their context and how they put together and what their experiences are to make sense of their experience. So there's a model and it's individualized. CBTP is very recovery focused and relationship focused. And everybody here knows in therapy in general, the common factors of relationship and alliance are just super important in seeing positive outcomes. CBT also has a structure for sessions that supports recovery, and I'll go into that in more detail a little later. And then there are practical strategies as well that have been developed over time. So we have a number of those as well to kind of work around problem solving and symptoms, things like that. So let me start with the theory part of it. And this is a quote that Brian found. And I think it summarizes it well that, to be effective in therapy, it needs to be grounded in some kind of theory, right? So, having too many frameworks to choose from, things can get kind of muddied. You might feel overwhelmed. Some theoretical frameworks are very constrictive, and so you might not be able to adapt to each situation. But if you don't have a theoretical background or some sort of framework to work within, then there's just a lot of facts and observations that are just there, right? We need to have a way to organize it in some fashion to kind of work with individuals. So in our view, the theory gives you that, something to hold on to, ground you. So let's think about that and in the context of two different symptom sets. One is hearing voices. Can you help me with hearing voices? And we would say from CBT that we think we can and certainly willing to try. Hearing voices is extremely distressing for folks a lot of times. Not always. Sometimes voices are seen somewhat friendly, but often it's a very unsettling experience. So From a CBT framework, we have a way of kind of understanding this that's been mapped out kind of over time. And many of you are familiar with this, many have been through this training, but CBT is all about, it's not so much the situation, but your response to the situation, how you think about it, that very much affects your feelings and then what you do about it. So this would be a common, what we call a maintenance cycle here that you see in front of you. And this is a pattern that we think maintains the distress for somebody who hears voices. And this is kind of general, but it fits. So there's some situation that contributes that involves environmental factors that often precede the hearing a voice experience. Individuals often have thoughts about that. They're often scared, feel threatened, and then have related thoughts like how much control they have. They may have thoughts about feeling weak or vulnerable, are very common when having a voice hearing experience. This often leads to distress. The distress often motivates what we call safety behaviors, which is some combination of avoidance or sometimes seeking reassurance in some fashion, sometimes with people, sometimes through certain rituals that people do that they think help, but often only contribute to distress over time. So there might be a short-term reduction, for instance, the classic, drinking alcohol to kind of get rid of it in that short term, but we know that over time it just increases the distress over time. Now, the other part about CBT that I think is helpful is that we have additional ways to kind of think about both a voice hearing experience and the thoughts that come from it. In the classic CBT model, early life experiences have a big impact on how a person sees themselves, how they see the world, how they see others, right? We call these core beliefs and schemas. All right. And so those early experiences could be trauma, could be other things we want to pay attention to because that will help us understand the particular way that a person thinks about themselves, sees themselves in the world. Something that's been added a bit more recently is more emphasis on kind of the social determinants or the societal influences that also shape or impact core beliefs and schemas. In particular, like Janae Steele has written a fair amount about, for individuals from in marginalized communities or experience discrimination, systemically and individually, these also have an impact on a person forms their kind of core beliefs and schemas. And so we need to take the full context into picture when we're trying to work with individuals. And we would argue that CBT has a framework that's flexible enough to do that and work with that individual. The next area that we want to focus on after the theory is CBT is very focused on recovery and relationships. I want to point you to the Brabin article that we have listed at the bottom when we look at recovery and relationship focus. They wrote a very good article on the ethics of CBT and how it really needs to be very hopeful and optimistic. There needs to be a lot of emphasis on a therapeutic alliance and especially co-equal partnerships, a lot of emphasis on shared decision making. So there's a lot of learning together that occurs. And that's really important in working with individuals who experience psychosis. The other part, building collaborative relationships. CBT sometimes gets a negative reputation of being a little bit like technique-y oriented, but it really does value, and CBT in particular has a lot of strategies for like how do we engage a person around their strengths? Can we work with values and their aspirations to kind of help them get to their goals? There's also a number of normalization strategies that we use to make the conversation around voices and other things, it's part of the human experience that sometimes people have. And so these things are ways that have been developed to try to improve or enhance at least some of the collaborative relationship potential. Talk a little bit about structure. So this is the next area. CBT is kind of known for having a format for how sessions go. We've simplified it into this acronym called START, right? So whenever an individual has a session, we first start with the relationship. So the conversation should begin kind of friendly. What's going on in your life? Kind of catch up with them on a very human level, always starting with that. The target part has to do with CBT usually sets an agenda for each session. Now, what's maybe a little different about this is the agenda is connected to their valued goals, right? So they might want voices to go away, but we would ask the question, what would be better if they went away? What do you want to do in your life? And so when we set those goals, we try to tie it to values and aspirations because that's where a lot of motivation comes. I had one of the individuals I worked with, one goal was to clean his room, but what was really underneath that was wanting to have people over. It was really relational, right? So cleaning his room had some motivation, but the idea of having friends over was way more motivating, right? So we try to connect that constantly in our work. The action phase is pretty straightforward, and that comes back to active listening, really understanding what's going on, and active collaboration. Throughout the session and near the end, we have something called review, and this is to purposefully with the individual, like kind of reflect on the session. What was helpful today? What did you take away? Is there anything you can do differently? And that serves two functions. One is to kind of help the cognitive skill of self-reflection, which is sometimes negatively impacted when a person experiences psychosis. So it creates opportunities to connect things up from the session. And the other part is empowerment, right? Like, so how can we make the session better? We give ownership. How would you like to see the session move forward? The last one is take home work, and that's really kind of figuring out how to do things outside of session, both for continuity. And we also know that from the research that when folks do homework, outcomes tend to be better. A little bit more, or the last part that we had in our list of what's beneficial is strategies. CBT has a number of strategies developed for working with psychosis. One of the key strategies is this guided discovery, sometimes called Socratic dialogue. And this is that process of asking curious questions to both show interest in what the person is experiencing, perhaps introduce alternative ways to look at the experience or add new information in. But it's really all in the service of helping the person make sense of their own experience and come to their own conclusions about things. Now, what this might require is the next little bullet there is coping with incomprehensibility. Sometimes the content is atypical, illogical, doesn't make sense to us. And we need to sit with that for a little bit and not try to correct it right away or say this is the answer. Require some humility and willingness to sit with that uncertainty as we struggle together to make sense of things. So one of the things that we talk about in CBT is we can be meaning-making agents, kind of help people to make sense of things. And then there's a whole range of practical strategies that have been developed over time, things like a voice diary to kind of help track when voices happen. There's a number of coping strategies for voice hearing that have been developed over time. And some of these are informed by lived experience of psychosis. So one strategy we talk about is scheduling time for the voices. So when the voices interfere, like really scheduling time to focus on those voices. This is a variation on worry postponement, which is something we use for anxiety. And it's also a strategy that some famous voice hearers have used. And so we can kind of use a normalizing framework and say, some Anthony Hopkins, when he had this experience, was able to schedule his voices. So there's a number of ways we can include this. And then the last point about the dialogue with voices is a more recent adaptation where there's been some work around having conversation with voices a little differently than kind of arguing. And if you're interested, that would be the Longden reference. Finally, just to kind of tie it back into CBT before I hand it on, there are very specific cognitive strategies, if you're familiar with CBT, that we use. A lot of it has to do with helping people think about their thoughts, if you will. How accurate or helpful is the way that I'm viewing this in this moment? What other information would I need? Things like that, and that's called cognitive restructuring. And with voices in particular, we often want to make the case or help them to see that they may have more control over their experience of voice hearing than they think they do. And there's also a number of behavioral strategies, which are mostly about trying to help people re-engage in their life. Then my final point before I pass it on is we always want to consider including family or other natural supports. It's just really vital. We spend only so much time with the individual in the office, and it's important for them to have networks and other people also able to kind of work with them to the best that we can, best of our ability. All right, so I'm going to pass it on to Brian.
Thank you, Harry. Let's talk a little bit about negative symptoms. A lot of times people with psychosis really do deal with a lot of negative symptoms, and they can become more prominent as a person learns to manage or recover from their hallucinations. Next slide here. Thank you. So again, that note about being grounded in a model is helpful here. So you'll see all of the essential elements of the cognitive model in this maintenance cycle as well. The situation and the environment the person's in, that triggers certain thoughts and emotional reactions and behaviors and outcomes. The difference is this cycle is adapted for those negative symptoms, with really a focus on the defeatist beliefs that tend to develop when a person is experiencing negative symptoms. And you can see some examples in the cycle there. I'm never going to get better. I can't do everything or anything. Beliefs like that. So it's important to note the differences in content of beliefs and then the resulting things that happen as a result of that. Now I'll add here a piece about social determinants. You can see in the top right corner, the same thing that Harry mentioned when we were doing the model for voices applies to negative symptoms. Their early life experiences and the more recent change or addition to CBT is focusing on those social determinants of health, particularly for people who experience marginalization or bias of some kind. And those also impact the beliefs that you form. And a lot of times, people who are marginalized can develop a belief of being inferior. They can receive messaging that way that can kind of mirror those defeatist beliefs that form for people who don't experience marginalization at the same level. So it's just good to make note of that. And again, thinking about the impact of family. So in some families, there can be a lot of criticism, and that can also cause negative symptoms to increase in their severity. And so at every opportunity when you're hearing about family dynamics and how they might be impacting a person, think about involving the family as well. So once you have a conceptualization of negative symptoms, really the critical part of addressing them is helping a person become active. Now, a lot of times we rush to the technique, but before you help a person become active, there has to be some discussion about the pros and cons of engaging in an activity. Everything comes with trade-offs, and engaging in some activities can be very anxiety provoking or just very difficult for people who are experiencing negative symptoms. So it's good to normalize that difficulty and educate them on ways that they can engage in those activities and also link it back to their values and goals. Again, thinking about social determinants. So you might suggest certain activities, but it really pays to pay attention to, can that person participate in the activity you're recommending? Do they have the financial resources to go to a gym? Or don't they? And if they don't, how can you adapt it so that they can still participate in that activity in a way that's accessible to them? And then you have a person attempt to engage in activity. You encourage them to try out new things, and then you help them reflect on their experience. And the key here is I want to focus on the attempts that they're making and not so much on the success, whatever that means, but more on the fact that they're trying to do something, really just highlighting the strength in trying and trying again. This is an example of an activities schedule that we created and we uploaded to iEcho. So feel free to go to the iEcho platform to download it. It looks very similar to other activity schedules you might find elsewhere, but the difference is we added a piece on identifying activities that are meaningful to the person. That way, it's linked to something that they really want to do. And then I'll also say here, like that first page, I kind of designed it with the idea of making it engaging and entertaining. And I want you to think about how your person that you're working with, what they find engaging, interesting, and entertaining, and try to tailor tools like this to their interests so that it's more compelling, more interesting for them. And then once they do create a schedule and they attempt to engage in an activity, be very intentional about reviewing what occurred and then linking it back to the thinking, right? So, what does it say about you that you were able to try to do something like this? Really kind of helping them build that bridge and form a new belief to replace the defeatist beliefs. And this is something that you're going to have to repeat because those defeatist and negative beliefs can be really sticky, right? And so you just might have to keep on engaging in that new activity and adjusting it and help them really feel the success and linking it back to, hey, what does this say about you? You're able to do it. So in summary, CBTP, very coherent, well-tested model. It is very relationship focused, and there is a lot of room to adapt the approach to different cultures, different races, ethnicities, different situations. It gives practical skills and strategies that help people lower their distress and pursue their valued goals and interests. And when it's done well, people are satisfied with it. And then I'll just make a pitch here. So a lot of you on this call are on first teams. Um, and for those who aren't, I'll just say that consulting with colleagues on difficult or complex cases can be really helpful. We all get stuck. We all have to think about how to individualize treatment to a particular situation or to a particular person. And sometimes it just helps to have another professional that you can bounce ideas off of. So consultation is one of those things that can help you with that. It also helps just like we're doing here now through this iEcho to have a community of professionals who are engaged in the same type of work that you are, encounter the same challenges, um, helps you relate, helps you not feel burned out, and helps you generate new ideas. So we encourage you to use consultation to your benefit and to the participants' benefit as well. And so with that, I'll just ask, are there any questions about CBTP?